Question for you. There's a few pieces of technology that we talking about. I have 4 of them that we'll review today. But are there ones in particular that matter more to you guys? Because the group that we had the other night, we kind of just did sort of a fast-track chunk of all 4. But is there something in particular, 1 in particular, or 2 in particular? Nope. You're good? All right. This is hard for me because reminds me of dental school, and I'm sure obviously it reminds you a lot of dental school sitting in those seats. It's not normally our style. So if you can, we'll try our best to make this more a give and a take like we normally do, where we're just chatting out loud. So just yell out loud, chime in at any point in time. I get bored standing up here and lonely. So we'll talk about each of the 4 pieces that we mentioned early on. Don't forget, a lot of this stuff is online. I know some of the videos are longer. We're going to work on cutting them down in the future, but this isn't school. We know if you're watching them only from the standpoint of we're tracking what you guys learn, so we know, next semester, the following semester, whether it's UB or another school, how we can get better and give you guys more of what you want. So don't be afraid if you're watching one of those videos and we ask you, I think there's like 5 comments we're asking you to make over the course of whatever videos you want. If you watch one and you're like, this is great, but it's way too long, Dave, this stinks, go ahead and say it. You're not going to offend us. This is about helping you guys the best we can help you. But they're there. There's a lot more there for CAD-CAM, quite frankly, because there's a lot more to know in CAD-CAM. But again, if you don't want to watch it and want to know it, it's okay with me. This is for you, and you take from it whatever you want to take from it. And then the last thing is, the live portions, we're not going to cut you off. We're going to do live events as often as you guys want them and need them to get really good at whatever you want to get really good at. So some of the pieces of technology, like intraoral cameras, it's not going to take you much to pick up a camera and get pretty proficient at using it. Today's cameras are pretty cool. Have you guys used them at all? Does anyone here use one? You have? In school or somewhere else? Okay. How was that? It was interesting because we had mixed reviews in the class on Thursday night. What did you like about it?
I don't know. It was quick pictures right up on the computer. I guess that was probably the best thing. But it was a real finicky device.
Okay, finicky as in it wouldn't get pictures, or?
Yeah, sometimes the computer wouldn't recognize that the camera was plugged in.
Got it. Okay. So that's actually a pretty good intro to. And those of you who've gotten to know me over the last 6, 8 months or so know that I'm you get what you pay for kind of person. There's cameras on this list that are pretty inexpensive. In fact, I couldn't tell you the exact price, but I think this Sony camera is like $500. And in the dental world, $500 is like 50 cents. So if you bought a 50-cent camera, you're getting a 50-cent camera, and they have issues. Sometimes they're not taking pictures when you want. It's like any other computer device that you plug in. A driver can get lost, and then it's got to find it again. And if you think about your day-to-day, if you're working with a patient, the last thing you want to do is pick a camera up and say, why is this thing not ready to take a picture? It's a pain in the butt, right? And if it's a pain in the butt, you're not going to use it. And trust me, if we're not going to use it, our hygienists aren't going to use it, our assistants aren't going to use it. And quite honestly, a lot of this technology gets maximized when we have other people in our office using it and not us. And this is one of those pieces of technology in our office and many offices that I don't often take pictures with this camera, but my team takes pictures with this camera all day long. So long story short, we're going to talk about one camera when you look at the online stuff, and when we do hands-on, we're going to have one camera in particular that we work with. And that's this guy here from Digital Doc, which is really head and shoulders above the rest. I like it for a couple reasons. It's lightweight. It's not a whole lot bigger than a high-speed handpiece. It's probably yay big. It's super, super light. It's expensive. It ranges between $7,500 and $10,000, so a lot more than 500 bucks. But the beauty of it, there's a few things that I guess are really, really slick about it. The first is, because it's so lightweight, it's portable. So in my office, we have 8 treatment rooms, and we often have 7 providers. I don't have 7 cameras in my office. That would be crazy to have $70,000 of intraoral cameras. We've got 2. But what we have in every room is a USB connector that hooks into the computer that sits in the room, so it's literally plug and play. Snap it on. clean it up, snap it off, and move on to the next room. So even though we've invested more money per camera, we're getting a lot of use out of the camera. The next thing I really like about it, and you can probably see this little dial over here, is it comes with a lot of different settings, so it's pretty versatile. Now, it's not as pristine as a traditional Canon or a Nikon or something that you guys would use if you're taking true digital images. So if I'm doing a cosmetic case, or I've got somebody who's got this big, huge, comprehensive treatment plan, and I'm trying to get them to really buy into their dentistry and see what I see, then that real camera gets busted out at some point. But that being said, at our first appointment, we've got 6 shots that we take on every single patient every single time with this camera. So the first setting on that camera allows me to take a full face. It's a little distorted. It's a little grainy. It's not quite as crisp as the other camera. But this picture lets me do an awful lot of stuff. One of the most important things it does is with all software today, you can load in patient photos. So now when any one of my patients walks in the practice, whether Lori or Sue's up front or somebody who normally isn't up front is there, they may have never met this patient, but they know who they are because their picture's sitting on our computer. And people, that whole relationship stuff that we've talked about in the past, it's about people liking you. And the first thing that happens when someone walks in the door, if they can say, hey, Eric, it's great to see you, that holds a lot of weight, as opposed to, hey, how are you? That look on their face, and I have that look a lot. So second picture we take is a smile picture. And that's a great picture for a lot of reasons. One, it helps people see what we see. And two, if you just take these 2 pictures and throw them up on a computer screen and walk out of the room for 5 minutes, it's incredible what people would diagnose all on their own. And you guys are probably, who's in clinic, I guess, first of all? Are you starting to see some of your patients are real easy, you can tell them anything, they say yes, but a lot of your patients, it's not quite so easy, and maybe they're a little skeptical, they want to know why they need it or if they need it. So it's incredible. Imagine what it would be like walking into your patient in clinic and you had pictures up and you walked away for 5 minutes, maybe you're getting their x-rays together, I don't know, maybe you're hunting down one of the attendings trying to figure out where they are, and you come back and say, so, how's it going? And somebody says, tell me about this. If they have an old composite or they've got decay or something's chipped or broken, people start to self-diagnose, which puts us in a great spot. So these are 2 of the pictures we take. These are the other 4 we take at a new patient. And she's a bad example, probably because she doesn't have a whole lot going on, but this happens too. But what I want is really like a quick preview of what's going on in my patient's mouth for myself, for my assistant, and for the patient themselves. So we can take a quick glance at anything and everything. And like I said, if I'm going to do something bigger and better, she obviously does not need a whole lot of dentistry, but if her teeth were really funky and we were going to do a lot of dentistry, I might follow up at a later date and make models and take a face bow and take some real photos. But for the most part, these are pretty good. And this camera does a nice job. These are nice images that you can take. And again, if you go back to that first slide, some of those cameras that cost $500, even up to $1,000 or $1,200, the image quality on those cameras are just not real good. And sometimes it gets frustrating because we're all kind of perfectionists, and once you've seen what a real camera can take, it's hard to go backwards. But for quick photos and make it real easy, especially when I know that my assistant or our hygienist can take all these pictures for me, it's great. Make sense? All right, so sometimes we use these cameras in hygiene as well. In fact, an awful lot. Same reasons. We take 4 pictures in hygiene. I'm only going to show you 2 of them here because they kind of relate to these 2. So our hygienists know to take 2 pictures of lower lingual. The first one they take is usually pre-treatment, because as you guys have seen, if you're in clinic, everybody has junk sitting behind their lower front teeth. And the second one they take is after they've cleaned it off. So it helps to build value. A patient understands why the heck they are in your chair. And when you leave here and it's in your office and somebody's paying $100 to $150 to get their teeth cleaned, this is a good reason to say, why? Why did I do that today? The other two photos our hygienists routinely take are of problems in patients' mouth. So sometimes, it's a bombed out molar that looks awful and it's really easy to see. Could be an old amalgam restoration, maybe it's a crack in a tooth. If they don't have anything wrong, our hygienists know, well, let's take 2 pictures of something that we've restored in the past. So maybe my partner did a crown on number 19 a year or 2 ago. It's okay for them to take a picture of number 19 and say, you know what, you're doing a great job taking care of this, and 2 years later it looks just like it did the day we placed it. It kind of reaffirms, again, building value of why we did what we did, why they come in every 6 months or 3 months or whatever that time frame is. And if everything looks perfect and they've never had any dentistry in the world, we still take 2 pictures and we compliment our patient for doing such a great job. Because there's not a lot of our patients who present to us that way. But imagine when you get that person who walks in and everything looks great every single time. Some of them are going to inherently be proud and they want to keep coming in every 6 months because they like for you us to tell them things look great. But some people at some point, especially we were talking a little bit about money and what people, how they think, someone's going to say, well, if I come every 6 months and nothing's ever wrong, why do I come? So a lot of times it's just good reinforcement to say, you're doing everything right at home, things are going well here, let's just keep doing what we're doing. So those are the 4 we take in hygiene. It's kind of a co-diagnosis thing pretty much all the way around. And then the third place we obviously use the camera is when we're in a restorative appointment. I don't think it's on here, but one of the places we now use the camera is, remember we did an Invisalign night at the office? So with this camera, we just upgraded our cameras probably 6 months ago. With the camera we have now, we can take our Invisalign photos with that as well. And again, if I don't have to come in and take those photos, if my assistant can take those photos, or a hygienist can, I'm saving a lot of time. So we use it for Invisalign in our restorative appointments. But we also use it for before and afters, like in hygiene, but big time, where most people sometimes miss it, is mid-treatment. So if you've been in clinic, you may have opened up a tooth and found a surprise inside the tooth that you didn't really think was going to be there. Does that ever happen to you guys? Happens a lot in practice. So, if you're not in clinic, you can probably even recognize that that doesn't look good. Like something's not right with that. And this just happened the other day. I was sitting in the room and I thought, you know what, I'm going to take this picture. Patient came in, we opened up a tooth, it looked pretty bad. I started cleaning out all the decay, it started looking really bad. And I thought, okay, I have 2 choices. I can keep doing what I'm doing and I know what to do. I've got to clean the cavity out, I've got to build the tooth up, I've got to clean up the prep, and then eventually we're going to put a crown on this tooth. But what are you thinking, for those of you who are in clinic, when you see something like that? What could happen with this tooth? Pulp out. And I'm not sure how you guys would feel. Is this going to be John? Yeah, it's John. We said we'd pick on you a little bit. How are you, John?
Good, how are you?
Good, thanks. The other opportunity that I have is to stop before I get in there and take all this decay out, in which case there's a good chance I'm either going to pulp out, and even if I don't, which I didn't on this tooth, there's still a real good chance this tooth is going endo. Now that patient, before they go home and they feel pain, or before I drop a burr into the middle of their pulp chamber and tell them, well, now you need a root canal. And what are they going to say if I just pulp out? What's their next question to me? Why don't you tell me, did I screw up, right? Guys, I'm going to steal a little juice here. Yeah, did I mess up? And it's a legitimate thing for a patient to think, isn't it? And that never, ever happens in dentistry, so. You'll find when you guys are in private practice that probably 50% of the time when somebody comes to your office and they've left another office, they're coming to you because they either feel that somebody messed up or maybe somebody did mess up. But it's mainly patient perception. So taking a mid-treatment picture allows me to stop and say, you know what, Abby, here's the deal. What do you think of this? Again, even who's not in clinic? When you look at that, do you think something's wrong? Yeah. Patients do too. And in fact, they're more grossed out about it than any of us are going to be. They just think, I see brown, I see caramel, I see blood. That's gross. So it's really easy for me to put that up and say, you know, things aren't looking as good as we expected them to look. So here's what we need to do. Here's what could happen. And I just wanted to let you know before we went in there and did that. Now if I pulp out, it's no big deal because they know about it. Now, and in this patient's case, if we get it all cleaned up, we build it up, and they go home, and we tell them about what could go wrong, and it happens, they expect it. So again, it's not a big deal, right? If we don't do those things, all of a sudden people start looking at us like we screwed up, and the next thing you know, they're calling, asking for their records, and they go see somebody down the street who's never, ever in a million years going to say, no, actually, the right thing was done. They're just going to be happy that person's in their chair. So it helps. Any questions on intraoral cameras? You guys will see when you start using them, it's pretty fast. In about 10 minutes, you'll all be really good at it. Yeah. No, that's a great question, and thank you for bringing it up, because one of the pieces that we will bring up are software systems that run offices, practice management systems. The better ones, which they're, EagleSoft is an excellent system. Patterson makes that. Dentrix is made by Henry Schein. That's also a very good system. I'm not sure who makes SoftDent, but those are kind of the big three. And I'm sure there are others that actually are pretty darn good, but those are the ones most dentists would know about. If you have any one of those systems, all of these pictures get stored in your patient's chart. So just like a digital x-ray or a chart note, are you guys charting everything in the computer, or you have a paper chart as well? Okay. So in our office, we've moved to having everything just computerized. And in your chart in my office, you know, your medical history is there, your financial history is there, your dental history, all that stuff. Everything related to your clinical dentistry is there, and then anything related to billing. It's all part of one big area, and it's all tabbed, and it's really, really simple to get to. So yeah, it's all in one spot, and it's pretty easy. And that's a really, let me backtrack for a second. That's also an advantage of a camera like this one because it's a USB plug and play. Now, some of the cameras out there are standalone units, and they actually are pretty good. There was one years ago called Reveal. I think AccuCam was one of the ones I listed on here. They have a plug-and-play USB, but they also have a standalone unit. The standalone units tend to take really, really good pictures, but they don't integrate as well as the USB drivers right into a patient chart. They're harder to get to. Have you seen that? Okay, yeah, you're nodding your head, I figured you saw one. And that's what we used to have. We had AccuCams, and they were great cameras because they took really, really crisp images. The problem was, if I wanted to look in your chart for it, it was a pain. And again, if it's not easy, you guys know, you're not going to do it. And if you're not going to do it, and it just becomes a $10,000 toy, what's the point? Anybody else? All right, so lasers. There's two basic types, right? There's a hard tissue laser, so you can prep teeth, you can take away bone, and then there are soft tissue lasers, which just deal with tissue for the most part. If you guys want to learn about hard tissue lasers, are there anyone think about pedo? Okay, hard tissue lasers are pretty cool for pedo. They're really good for, in fact, teeth that have never been worked on before, in direct restorative dentistry. What hard tissues aren't as good as we hoped they would be for is, prepping a crown, prepping an onlay, and taking out old materials. So if you've got a tooth with a big old amalgam in it and you want to get that out, it's going to take you probably 30 seconds to take it out with a high-speed handpiece once you guys get really used to using a high-speed. And it'll take you 10 minutes to take it out with a hard tissue laser. So who's using a laser? Me neither. It's cool, but 10 minutes is a long time for a patient to sit there when we all know it can be out of there in under a minute. Yeah? So, the theory behind no anesthesia, is that a laser emits energy, whether it's hard or soft. And if you start off on a low pulse of energy, then what you can do is you can anesthetize a tooth in the process. So if you start off on a real low wavelength, and then you raise it up, and you raise it up, and you raise it up, in theory, you can work on a tooth without anesthesia. And I would tell you, being 100% honest with you, as someone who doesn't use a hard tissue day to day, I probably would get a patient numb, because quite frankly, I'm not as good at it as somebody who's been using one all day, every single day. Those people are probably excellent, and they probably rarely give anesthesia for anything. So that is an advantage to using it. There's a pediatric dentist in our plaza who's probably going to be purchasing one really soon. So, and there are people in the community who have one. So if you guys want to see a hard tissue laser in action, let us know, and we'll arrange it with people we know so you can get in their office and see what they're like. They are cool. I've used them in the past. And BioLase is probably the biggest player in hard tissue lasers. They've been around the longest. They do pretty well with them. We use soft tissue lasers, on the other hand, all day, every day. It makes life really super easy. And just like intraoral cameras, there's a bunch of people who do it a little bit different than intraoral cameras. All of these lasers, from a function standpoint, a pure, like, take away tissue and get hemostasis, they're all the same. They're all going to market to you really, really well and tell you why this wavelength is better than this wavelength. But quite honestly, no one's ever been able to prove that, powering up over here makes any difference in powering up over here. So don't listen to any of it. The difference in price comes with ease of use. So let's see. So if you want a laser that works like your iPhone, there are companies, and you're going to spend a little more money, but it can work just like an iPhone. It sets up, it has apps on it, essentially. And if you want to trough for exposing a decay, you've got a cavity underneath tissue and you can't see it. If you want to eliminate that tissue, you literally push a button that says, take away tissue. If you want to do a gingivectomy, and I'll show you some pictures, so for those of you who aren't in clinic, you'll get a little bit more understanding. There's a button you push. If you want to do a frenectomy, there's a button you push. I like that because, again, I want to make this as easy on myself and as easy on my team as I can, because we use it if it's easy. So price is based on, I guess, features. And again, BioLase makes a pretty good one. Sirona makes a pretty good one. Ivoclar makes a pretty darn good one, simply from ease of use. Outside of that, if you want to spend $1,000 on a laser or you want to spend $10,000 on a laser for pure work, it makes no difference. You can, if you don't care about pressing buttons, if you're okay with setting dials, spend $1,000 and not 10, and you'll get the same job done. Make sense? All right, let's see. So, one of the most important things I want to teach you about lasers, because you're going to hear different things from different people, is why would I use a laser when I can, 1, pack cord, 2, use an electrosurgery unit, or 3, use a scalpel and cut tissue. So, any of you guys have an idea why you might want to use a laser as opposed to one of those things? Bleeding, a great reason. Efficiency is a great reason. Pain is an excellent reason. I'm sorry? Accuracy is huge. Tissue healing is huge. And those kind of go hand in hand. Actually, pain, accuracy, and tissue healing are all part of the same process. So yeah. Why wouldn't you want to use a laser? What's the knock on it? You guys know? It's the, I'll give you, it's the reason you won't buy an iPhone, but you buy a flip phone. Cost. It costs more. So people in certain arenas will say, why would you buy a laser when you can buy cord, and a little thing of cord costs $50, and you could probably pack that on 200 teeth. So it costs you $1 every time you pack cord, as opposed to a $10,000 laser. And all the reasons you guys brought up are the great reasons why you would. And somebody said efficiency. In the short run, you can get pretty good at packing cord, but it takes the average person, I believe, 2 minutes to pack a cord well. And I think they lined up like 100 great dentists in a room, and they said, pack cord, and let's see how long it takes you to do a great job. And it came out to like 2 minutes. And then they looked at how long does it take you to use a laser to expose a margin and do what cord does. And they found out, wow, look at that, it takes 45 seconds. So, in this room real fast, we think, 45 seconds, 2 minutes, what's the big deal? But what if you work on 8 teeth a day, 5 days a week, 200 days a year? Then all of a sudden you can figure out that over the course of about a year and a half, your laser is now free. And every time you use your laser after that, you're far more efficient and far more effective from a cost standpoint. From a doing the job really, really well, the laser is phenomenal. It does a lot of really, really cool stuff. So sometimes we use a laser in perio. You guys learned about frenums and how they can pull on tissue and do nasty things. It's great. Patients love it. It takes me to take that frenal attachment away probably 2 minutes. And as you brought up before, no anesthesia. Depending on the patient, if I have a really good patient who's pretty calm in my chair, if I put topical on this attachment, I can do that with no anesthetic. If I have kind of a high-strung patient, I'm going to give them a little anesthesia and zap that thing away in no time at all. It's really fast. It's really efficient. There's no bleeding, as somebody mentioned. There's no pain. There's no post-operative pain. So they go home and everything is wonderful in the world. Have you guys seen a frenectomy in school? Anyone seen one? So the other alternative to a frenectomy is you take a scalpel blade and you make like a diamond. So you cut, cut, and you remove that whole piece, and then you have to take these two pieces, kind of like drapes, and you take stitches and you sew it up. It's not the end of the world, but that's no fun. Yeah? It's awesome. In fact, I'll tell you the very worst thing I hear from people, and this happens if I use the laser on 10 patients, I'll tell you 5 people come back and tell me, I felt nothing. 5 people come back and tell me, it was kind of like eating hot soup or pizza. When you eat pizza a little too quick and you know it's going to be hot, but you just do it anyway. It's the same sort of sensation. That's the worst it gets with the laser. Unless, like everything else in life, you don't know what you're doing, and instead of pressing the button that says frenectomy, you decide that that's taking you a little too long, so you press a button that dials the power way up here, and you just burn it away. Then it becomes like using an electrosurgery. Have you guys used an electrosurgery unit, those of you in clinic? Yeah. So here's my, electrosurgeries aren't bad. I mean, they're really efficient, right? I mean, you probably didn't, could took you a couple minutes to take that for neck.
Oh, I didn't do it. You got it done by one of the therapists. They were friendly.
Thank God they were friends and they didn't charge him, right? That would have been bad. Let's see. So the reason I put this up here, we call it burning the toast because we're dental nerds and we have to make up stuff for everything. But what electrosurgeons do is they're high power, high heat. So you can melt anything away that you would use a laser for with an electrosurgery unit, and it'll melt it away. In fact, it'll melt it away a little too easily. So what happens, why you generate so much pain with an electrosurgery unit is you're not only taking away tissue, but you're literally burning all the cells. I think it's up to like 2.5 millimeters that you don't see, you and I don't see. So if you think you're cutting this, you're really also cutting a couple millimeters deeper than that, and that tissue is necrosing. And you guys probably are learning, even in second year and first year maybe a little bit, that when you necrose tissue, it hurts like hell. Right? What's the most painful thing in oral surgery that can happen? Someone takes a tooth out. Dry socket, because bone is dying. So imagine you take an electrosurge and you're burning this tissue away, and maybe you're close to bone. What's happening? You're burning the bone. It hurts. So, one of you guys mentioned accuracy with the laser. One of the greatest gifts of a laser is if I touch the tip of the laser here, the only place it's working is where I'm touching that tip. Unless, of course, like I said, I dial it up to a bad place. But you have to try hard to hurt somebody with a laser. You really, really do. It's not a crazy beam that fires all over. I was hoping for a light show. It doesn't happen. It's just a little, I think it's on this, it's a little glass fiber that comes out, and there may be a better slide than here. And just the very tip of that glass fiber is what's working. And you guys will see it when we do hands-on. It's really cool. Yeah, you do. And it's interesting. There are those people who manufacture lasers who will tell you, well, maybe you don't have to wear them. Maybe you should, you shouldn't. But I don't know. I kind of like seeing. So they make traditional goggles. So if you don't wear loupes, or for your patient, or for your assistant or hygienist, they can just wear regular goggles. But they also make attachments. Are most of you guys wearing loupes now? Do you have to wear them in clinic? That's a good thing. So they make an attachment, and it hooks right onto your loop, so you're looking through. It works out pretty well. If you want to make a fortune in dentistry, I've tried to convince at least 10 optometrists to do this. Start making laser goggles. They're like $300 for a pair of plastic things. You're going to laugh when you see them. They look like the cheapest 1960s version of ski goggles you've ever seen. And they're $300 a pop. So if you guys want to quit dental school, you can make a lot of money. So sometimes we do frenectomies. This is actually a little better picture. It's a little glass rod comes out of here. The tip of it's doing all the work. And this is what you see, which is really cool. So if you deal with an electrosurge, you deal with a scalpel, and you try to cut this tissue, it's kind of bloody. It's really messy. But when I'm working with the laser and I've pressed the right button, it's really clean. So I'm just kind of melting tissue away a little bit at a time. And the more I take away, the more I see, the faster it goes. It's really, really simple. And when you do a procedure like this, again, it's so painless, it's awesome. Yes? Good question. I will tell you that in the world of dentistry, when you get set free from dental school, there are a lot of things that you should get continuing education for. And there are a lot of companies out there that want to sell you something that will give you continuing education just because you bought an expensive piece of technology. So someone will train you on using the laser when you buy it, but it will behoove you to go out and take a day-long class or 2-day-long class to learn how to use it. That's the beauty of what we're going to do. Is we may not be able to see every laser that's out there, but when you come and do the hands-on stuff, I promise you, you'll learn how to use it. And if you don't the first time you come and you want to do it again, or 20 times before you graduate dental school, we'll do it until you walk out of school and you know that you can use it. And actually, we had someone ask this the other day, and I'll find out the answer. I don't know today. But we may be able to get you guys certified to use pieces of technology like this that, in theory, there's an advantage to get certification. So I'm going to try to do that. I'm not sure if they'll do it on a student level or on a generic level. But it'd be pretty cool to walk out of school and have all your certification. You're not going to get credits for it that you'll need later on, but who cares? There's plenty of opportunity for that. And if you can walk out with it and not pay somebody $2,000 to get certified, that'd be cool. You guys can buy me a beer someday. This is, I don't know if there's one more or not. This is kind of bizarre story, but we talked a little bit in the past about how technology can be a big practice builder. And some of the stuff that's online deals with return on investment. I think you asked about it, so we did a little segment on it. But it's kind of odd, and I'm not sure if it's good or bad, but in our office about 10 years ago, we had a newborn come in, and very panicked parents who said, my baby can't feed. And we were told that you've got a laser, and our alternative is to bring our baby to the OR under general anesthesia and have this little freedom cut. Can you help us? So it was a stressful day, but long story short, we were able to get a laser in on this 1-week-old, got the tissue out of the way, and now for better or for worse, we get a lot of patients from every lactation specialist in Western New York sending us newborn kids, out of control. And the really cool thing is because they're so little, there's no, there's no muscle, there's no innervation in this. When you're a week old, it's just like this thin, tiny little piece of tissue. And it's scary to think, do any of you guys have kids? I mean, what would it be like if somebody told you a week later, we're going to bring your kid to the OR? It would be bad, right? It would be horrifying, yet alone everything else that comes with it. So long story short, with technology comes opportunity. So those are a little bit stressful at times when those kids come in, not so much for the procedure, because what I know is a 1-week-old, they're not going to feel anything with this laser at all. The hardest part is to get the parents to calm down, because I need their baby to cry, to open their mouth. You know, that's the only way I can kind of get my fingers in there. And again, it's fast. It takes us probably 5 minutes to do on an infant, only because we do a little bit, we stop, we do a little bit, we stop. It's more for the parents than it is for the baby. But we do a lot of frenectomies on newborns. Kind of cool. One of my favorite things to do with a laser is whenever we're doing anything for a patient to improve the way their tissue looks. So you guys are going to see post-orthodontics, almost, I'm going to say 80–85% of your patients are going to come back post-ortho, and you're going to have uneven heights of tissue. Have you guys seen that or know anybody where you look at them, you're like, they've got nice teeth, but their gums are all whacked out? Lasers are awesome. So years ago, if you wanted to move tissue, 3 millimeters on anybody, you had to go to a periodontist, and same thing. They took a scalpel, they cut tissue, they moved it, maybe they trimmed bone. There were a dozen stitches that got put in, and it became kind of a cumbersome procedure that a lot of people didn't want to go through. I don't know that I would want to go through it. But in today's world, if you've got a laser, something like this to do, this is obviously half the mouth, and I apologize, this is a little overexposed, but usually we'll go bye to bye. It takes probably 20 to 25 minutes to get a really, really great result, and people walk out the door and they look entirely different. And this heals, I would say, within 5 days, this tissue looks pretty normal, and in about 14 days, the tissue is really mature, because I'm not taking a ton of tissue. And the only thing I have to be careful of, have you guys all taken perio at this point? What do I need to be careful with when I'm taking tissue away? Attachment loss. So what would make that happen? If I'm... Exactly. Exactly. So the only thing I have to pay attention to is where the bone is in relation to the crust of the tissue, right? As long as I do my homework and I sound bone, which is really not as heinous as they teach you in school to do, and it's okay. Once I've made sure, you can actually see kind of the marks where I was making sure where the bone was. Once I know where that bone is, and then I'm not going to violate biologic width, I can move tissue wherever I want really, really predictably. And that was somebody else's comment of precision, is if I move this tissue here with the laser, what I know is that's where the tissue is going to stay as long as I obey the rules. If somebody comes in and I do this with an electrosurge unit, that tissue's not going to stay there because of what we talked about earlier, necrosis, right? If I'm burning stuff that's deeper than what I can see, then tissue's going to change even more. So if you walk out of my office and things look great, chances are you're going to come back and that tissue's going to go up a little bit higher than I wanted it to, and maybe you're not as happy as we all wanted you to be. And then if I try to guess and say, well, I'm using electrosurge, I know I'm going to burn it, so instead of coming up to where I want to, I'm going to come here. What if I only got down to 2 millimeters instead of 2.5? You know what I mean? It just gets unpredictable. So for me, the cost of a laser, that investment, is worth all the cool stuff you can do. We're doing good? All right, cool. Has anyone seen imaging? 3D imaging? CAD? Yeah? Have you seen it? Where have you seen it? In private practice? Yeah, what did they use it for? Okay. Did you get to see like pre-op scan or the whole process? What did you get to see? That's cool. Okay. Uh-huh. What'd you think?
Pretty nice. I like especially the fact that you also get the benefit of having a digital pen as well.
Yeah.
And it's so small. And then it saves, like the author said one thing, you don't have to have a developer either.
Yeah, very cool. Has anyone else seen one? Okay. Cool. Who teaches that one? Okay. Okay. I was gonna say at your house. All right. Yeah, it's they're expensive. They run between $150,000 and $250,000. The good news is they're becoming more prevalent. So it used to be a hospital or like a center, but more and more as people's two-dimensional pans are dying and somebody's looking at a system, people are starting to evaluate the system and say, does it make sense for me to bring into my office or not? In fact, I think Sirona makes one of their units is like $90,000. And a high-end 2D pan is probably $50,000. And again, it's double almost, but you start getting into that kind of numbers. You start to say, well, what are the benefits of 3D versus 2D? So, well, other than cost, what's a downside to taking a 3D scan? I'm sorry? Yep. Yeah, you're all right. It depends on the system. So you can, if you look at it, the easiest way to look at it, I guess I should say, is, as you mentioned, there are systems for dentistry that basically take an image from here up. That's more radiation. That's more exposure. And there are systems that take, kind of a chunk, and they window it right here. And that is less exposure than a 2D pan today, which is cool. So the upside to that 3D picture is we get a lot more data and a lot more application. The only downside to that image is depending on the size of somebody's head, which is weird to say. But if you got someone with a giant head and you have an image that's only this big, then it's possible to cut off the condyles and the joint, right? And I want to see the joint. So I have to be careful if I'm going to use this technology on somebody with a giant head. But for the average person, you get what you need. Yep. Uh-huh. Mm-hmm. Yeah. Yeah. And sometimes it's hard too because these are the big players in the game, but there are more. But when you guys learn more and more and more, you're probably going to hear Gendex, iCat, Sirona over and over and over again because they've been around they've been in the game longest. But so sometimes it's tough to say, and from a manufacturer and a distribution standpoint, that's the message that they tell us. You know what I mean? If you walked in and said, "So tell me how much one of these systems are," it's going to be, "Well, I want to tell you about everything about it first, and then you tell me what you need, and then we'll talk about how much it is," because they can plug and unplug things to jockey price to get people in it. So sometimes there's a little more than meets the eye, and sometimes it's all about how they present the product to you. But it's pretty cool technology. It's great. Maybe. It does an awful lot of stuff. So the most common place you guys are going to learn about it in school is implants and treatment planning. And quite honestly, that's probably the most common use for it, day to day and private practice. That's what most people think of when they think of 3D imaging, because it does that so well. So you see images in class, at least you get to see the images. Have they taken you through cases and stuff? That's good. All right, so have you guys in the back, you're probably not quite to that point yet, yeah? Oh, awesome. Okay. Really cool. All right, that's good that you're getting exposed to it. It's phenomenal for treatment planning. The stuff you can see is amazing. So obviously, implants are what you guys know about. It's great for oral, any kind of surgery, but oral surgery in general. I mean, imagine taking out thirds. What would be the advantage of a 3D scan instead of a pan? Yeah, I mean, how many pans have you guys seen where you looked at the third molars and people said, whoa, those are sitting right on top of the nerve? If you had a three-dimensional scan of that, probably 70% of them really aren't sitting on the nerve. They're left of it, right of it, beneath it, above it. Sometimes they're super far away, we just can't see it. So it's awesome for anything in oral surgery. Our oral surgeons smile all the time, and they take this scan on every single person who walks in, because their unit is one where they can narrow that beam and they can focus in. It's pretty cool. In fact, on some of the systems that are out there, you can pull out a PA, which is really cool. You want to focus on stuff, and I think it's on here, endo. Some of the endodontists out there are now using 3D imaging to see where these canals kind of wind and twist around, and it's incredible what you can do with it. And imagine how little exposure is when you shrink it from here, down to that. And imagine how detailed that picture is when you shrink that image down to that. It's incredible. So a lot of the endodontists are starting to move in the direction of 3D imaging, kind of as a complement to microscopes, which are pretty mainstream in endo today. Is anyone thinking about endo? No? Yeah? You know what? The good thing, think about what just happened there. So there's one person in a room of 30 who wants to do endo. That's good math, right? Because chances are, if you guys don't want to go into endo and you're anything like I am, you don't like to do it that much either, which means you can do a lot of work. It's good stuff. So endo is a great place for it. Orthodontists love it a lot too, right? It really tells people where tooth position is, especially imagine if somebody had impacted cuspids and they're trying to figure out how are we going to get to these things and talk to a surgeon about exposing it and pulling it down. What's the best place to put force? How do we do that? So orthodontists love them. From a restorative standpoint, we love it because it goes hand in hand with implants. And I'll show you a case that a friend of mine did where it takes CEREC and it takes three-dimensional scans, and it marries the two, and it makes the patient experience entirely different. It's really cool stuff. And it makes our job really, really easy. And then it's great for trauma also. Anything surgically driven, it's awesome for. So this is, a friend of mine did this. His name is August de Oliveira. He's a California guy. He's a general dentist, and he does tons and tons of implants. His practice is mostly focused on implants and restorative and how they come together. So he owns the Galileos, which is one of the imaging systems, and he also owns CEREC. So if he has a patient who comes in and they're missing a tooth, he takes a scan without a tooth there. And then what's really cool, we'll kind of work through this, you'll see it as we go through the next 3 slides. He can actually build that final tooth before the patient ever goes to have surgery, which is awesome. And it's maybe not from a time management standpoint tremendously important on a second molar, because if you and I were missing a second molar, we'd probably be okay living without it for 6 to 8 months. It wouldn't ruin our life. But imagine if you were missing 7 through 10. That would be awful to have to walk around. Have you guys made flippers in school? You ever had a patient wear a flipper? They're no fun. People hate them. They're great. We need them, right? We need people to be able to walk around with something that's looks pretty good, It doesn't require us to work on adjacent teeth. It doesn't put pressure on tissue, because one of the things, if you haven't learned much about implants yet, is the kiss of death for an implant is when you put force on it before it's ready to have force. Now, some implants, you can put force on them right away, and some need time to heal. So flippers are a nice way for those implants that we don't want to put force on right away to buy us time. But imagine you're the patient who gets in an accident and you're missing 1, 2, or 4 of your front teeth, and somebody tells you what we told everybody to you 2, 3 years ago, as short as that time frame. It's going to be 2 years before your teeth are there. That would be really bad. You know, I'm going to be without my front. I mean, I'm 25, 26 years old, and I'm not going to have my front teeth for 2 years. And shockingly, we get a lot of people who are your age and younger who, you know, not last night, Friday night, because we're all here, but on a Friday night, you know, maybe they black out by accident on the concrete. We had a kid just this last week. It's terrible. He's 20 years old. He had his jaw wired and set about 2 months ago, and we literally just restored 28 teeth in his mouth with the caveat that, by the way, you probably have 5 years, and you're going to start losing teeth. But he's 20, so we're really hoping that he's going to be the exception to the rule, and we're talking 10 years from now. But he just sheared all of his teeth because he face planted from, someone must have spiked his water, I'm not sure. But it's bad. So anyway, back to this. So this is just a kind of a picture to track you through of, you know, pre-op we take an image. That's the implant fixture in place. That's an, you know, the abutment for the implant in place. If you want to look how it, you know, plays out on a model, same thing from a lateral view. Implant on the model, you know, fixture making an attachment, we make an abutment. It goes to the patient's mouth. And then in the end story, you know, he planned this before any surgery was done, and the shape of this tooth was actually determined before a patient ever had surgery. It's really cool. So with CEREC, what you can do is this image here allows you to build this tooth. Now, imagine, like, have you seen guides, surgical guides in oral surgery for implants? You made them? Okay. So they're not bad, right? But you're still kind of guessing. But imagine if you could make a surgical guide and you knew exactly where this tooth was going to be, not just in position, but you knew the occlusion, you knew the exact buccal contour, the lingual, everything about that tooth you knew. And you could take that and use that to do your surgery, and then you could build this whole process. It would be a home run every single time. You know, no one would ever put an implant in at an off angle because they would know exactly where that tooth was. And if they put it at the wrong angle, it would be somebody making a, you know, a clinical choice to say, I know it's supposed to be here, but I have to do this, which will never happen in your professional careers, I know. So last but not least, we'll crank through this pretty quickly, is CEREC. These are the competitors. E4D is made by Henry Schein. It's not a bad unit, but there are disadvantages of it compared to this one. Advantage is price, but again, we all know how I feel about price. Get what you pay for. iTero used to be owned by a company called Cadent, but now Invisalign owns iTero, so Align Technology owns this one. And Lava Scanner is by 3M. So I'll kind of go backwards. What I'll tell you about Lava Scanner is I have about 30 patients who work for 3M in my office. So I've offered to them for them to bring their Lava Scanner in and we would restore their teeth with it. I've never had someone say yes. That kind of tells me a little story about what they think of their scanner today. Now, probably in a year, 2 years, or 5 years, when they're in the game for a longer period of time, they're going to feel a little more comfortable about their technology, and that will change. But as we sit here today, this is really in its infancy, and probably not one that you're going to make a choice from if you were buying it right now. A significant amount of people buy iTero. Have you guys seen that system? Okay. So iTero is, the camera on iTero is not bad as far as the image quality that you get. It takes a pretty decent picture. The problem with it is, no exaggeration, and I'll have them bring it to the office so you guys can see it. The camera's like a rocket ship. It's like this big. It's crazy. So imagine you're used to working with a, you know, a handpiece that's like this, and now somebody says, take some pictures in your patient's mouth with this. It's ridiculous. And it sounds like you know, a jet airplane is happening. So it's not my favorite piece of technology. Why you might want to do it, why people are purchasing iTero today is because Invisalign owns it. So they have a deal. If instead of making a physical impression, if you make a digital impression with iTero, instead of it being a 2-week turnaround, it's a 2-day turnaround. Instead of it being, $2,000 for your lab fee, it's, I don't know, like $1,700 for your lab fee. So they're trying to get people on board their technology ship, which makes sense, right? That's logical to do. The good news is, and I can't say it out loud, but I'll say it out loud, is in 2 months, 3 months, Sirona has the same deal with iTero. Because what Invisalign has figured out is most people who've done their homework know that right now this is the best camera on the market. So there are a lot more people who own this than will ever own this. So Align Technology said, hey, we better start playing with the big boys or eventually we're going to lose the game, because Sirona's smart enough to go out there and build another Invisalign and do the formula in the opposite direction. We've already got the camera. We're going to teach you how to move teeth. Go ahead and do this. There's all sorts of politics going on behind the scenes, so it doesn't end in dental school. It's kind of a life thing. E4D is not bad. The only thing I'll tell you as far as why this and not this is really the camera. This is what you now get with OmniCam with CEREC. So some of you guys were at Ivoclar when we went there and we used the blue cam. And when we do hands-on, we're going to have both camera systems for you guys to play around with, because quite frankly, both are going to be on the market. And some of you will go to offices that use a blue cam, and some of you will go to offices that use the OmniCam. If you purchase one today, cost of the OmniCam is about $130,000. Cost of the blue cam is about, I don't know, maybe $95,000 or $100,000. Again, if you're going to make that kind of investment, in my eyes, you spend more money, and there's a whole host of reasons why this is a better camera, because it's the latest and greatest. But not the least of which is it makes our life easier, and you guys will see hands-on how simple this camera is to use. How many people were at Ivoclar? Okay, you guys were there. What did you, I mean, the cool thing about blue cameras, it's not terribly hard to use, right? You took pictures, not so bad. Powdering isn't so bad, right? The nice part about OmniCam, there's no more powder, which is nice. It's not a still picture, which all the systems, including the blue cam, are. They're a still click, 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 click. So you're taking a series of pictures. Now the good news is when you get really good at taking pictures, it's not a big deal, because you can line up one picture after another and after another. And all of us are pretty good at that, because they let us into dental school because someone told us at some point that we saw things and our hands worked with them. So that's good. But the cool thing with OmniCam is it takes all of that away, it brings it in full color, and it's video. So now I don't have to worry about any of my pictures lining up anymore. All I have to do is take my little camera, which is a lot smaller than the blue cam, by the way. It's pretty cool. And I literally just roll around, and I'm shooting video. And it's kind of like fill in the blanks. If I look at my picture on the screen and I say, whoa, I'm missing this piece here, and I want it, I just go back and videotape it. And if I video and I put my camera back down and I say, you know what, maybe I want something different, I can go ahead and pick it up and do it. Where right now, if I'm using powder, I might have to rinse the patient's mouth off, put powder on again, keep it dry. Not with this. You just dry it off and go, 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 go. So it's really, really cool. All day and all the time to build crowns. We build partial crowns. I don't do a lot of veneers in my office just because of my school of thought of how a restoration should look. So we capture images with our CEREC for veneers, but then we send those images to our lab and we let our lab build veneers for us. But it's perfectly capable of building a veneer. Restoring implants, that last set of images, it does an awesome job with that. With bridges, it works very similarly to how we do veneers. We take images, that goes to a lab, and our lab does what they've always done. Only now, they've got something that is a much more accurate model than if we had made a physical impression and they poured it in stone, et cetera, et cetera. Not a bad way, the way we've done it in dentistry for 200 years, but we just have a better way now. Pretty cool. This is the piece that gets really undervalued, I think, and I put this on here because, again, when I talk about you invest in something, maybe you spend a little bit more money, but it carries a lot of weight. You guys in school take diagnostic impressions and face bows on everybody, right? Is it fun? Do they like it? Is it worth it, though? I mean, if you didn't have to do it, but you had all that information, is it worth having? Yeah, it's good information. Imagine if in 5 minutes you could image a patient's entire mouth, you could take a bite registration, and you could have all that information on a computer screen right there. That's really powerful information. Now I have everything I need. My assistant didn't need to make those physical impressions. My patients didn't need the goop. I have them right then and there. I don't have to wait for another appointment. It's instant. And on top of it, if I'm really, really smart, I ask my patient the same question I just asked you. Anyone ever take that impression material? They make the same face you all just made, right? No one likes it, especially if you had ortho. I had those impressions, what, every 3 weeks I had somebody putting junk in my mouth. It's not bad, but we've got better. So from a practice, I guess, marketing standpoint, you would say, if I'm smart and I talk about this right with my patients, now it becomes a tool to reinforce why a patient's coming and sitting in our chair instead of going in the office down the street. So there's so many benefits to it. I love it. This is how the system works, just as a quick view for you. You have choices, which I really, really like. And some of you have heard me say, you know, if all you have is a hammer, everything looks like a nail. That was a huge knock on CAD/CAM for a lot of years. If I spent $130,000 on CAD/CAM, then as a dentist, I might feel like every single patient had to have a CAD/CAM crown, even if that wasn't necessarily the best thing for them. I agree with that because that happens sometimes in dentistry. None of us it happens to, but it happens. The cool part with Sirona is it allows us to sort of take that whole equation away. So if I feel like in my hands some type of ceramic unit is in their best interest, then I can live on this side of the slide. And I can build their crown or their inlay or the onlay for them. But if I feel like I do, that my lab is better at making front teeth look pretty than I am, you know, he's going to put in more time than I am, then I can live on this side of the slide, and I can still use the camera to capture everything, and I can let my lab do the rest of the work just like he's always done it. So now I've got the best of both worlds, and it's why I think I really like this system. I don't feel locked in into doing something one way. I can always do what the best thing is for my patient, and your patients are going to understand that. They get it. So real fast, we won't go through this. This is all online. I know some of them are a little long. I apologize. But essentially, they give you a type it on. And you can pick whether it's 1 tooth or 28 teeth. You can treatment plan all from the screen. And you can treatment plan them one at a time, or you can treatment plan it to do it all in one day, all from here, which is really cool. Once you've figured out what tooth or teeth you're going to work on, you can tell CEREC what you're going to do. Am I going to make a crown? Am I going to make a partial crown? And you can select that for any number of teeth. Then you select what mode you're going to work on. And each one of these modes has an advantage or a disadvantage, which you guys will see online. And when we do hands-on, when we're building teeth, you'll really see it. So there are strengths and weaknesses to each one, and we'll get to all that. But once you know the tooth and you know the type of restoration, and you know how you want to build it, let's skip through all this fun stuff. Get you out of here. You select a material. So if I'm going to build this unit, whatever it is in my office, I have a lot of companies to choose from. I can use Sirona, Vita, Ivoclar, Mertzer, 3M. Just a quick heads up, and for those of you who are at Ivoclar, you might remember this. These two guys, Sirona and Vita, the materials are identical. So what Sirona said was, hey, we don't want to manufacture our own blocks. So Vita, if you could make us blocks and leave them blank, we're just going to stamp our name on them. So Sirona blocks and Vita are identical. Basically, if you choose to use that type of ceramic, whoever's got the best deal going, those are the blocks you buy, because it's the same exact stuff. Ivoclar said, we're not really going to play that game. We like our materials, and we want to be the only supplier of our materials. So if you like Ivoclar's stuff, they've got a whole selection of materials down here. They're my personal bias. They've got 25 years of history They have the only ceramic that's still available today, 25 years later, in Empress. It's the only one on the market that was here, a quarter of a century ago. I like that. That says something to me. It's kind of stood the test of time. A lot of the other materials have kind of come and gone and come and gone. Theirs have not. So that holds value to me as a dentist. Makes me confident to know that when I'm placing a restoration of a patient's mouth, that it's not just my personal experience, that I've got restorations that have lasted 15, 20 years. It's a whole lot of people all around the world who've been doing this for longer than I've been doing it. Mertz really makes temporary materials. I don't use their stuff, so I can't tell you good, bad, or indifferent about it. And 3M makes the latest generation of blocks, which is, they call it zirconia, but it's really not a zirconia block. It's kind of a hybrid of a material. So I don't know, you take dental materials, right? Have you learned about like sculpture or, I'm trying to think, bell glass? You took it in first year? Okay, so that hasn't changed. All right, same for me. So long story short, about 10 years ago, there was a whole group of materials that were really cool. They were half composite and they were half porcelain. And what they said is, composite's really good because it's flexible and we can add and subtract to it, which is really cool. So if something chips, I can take a flowable resin or even a packable resin and I can add it to a restoration. So that's neat. That might be cool to have a restoration we can do that to. And then they said ceramic's really great because it's a lot more durable and it looks a lot nicer than a pure composite looks. So they married the two materials together, and there were probably a half a dozen companies who manufactured materials along that vein, like I said, maybe 10 or so years ago. So at some point, all ceramic restorations started figuring out the weaknesses of the ceramic, and all those materials went away in dentistry because there weren't enough of us who were buying them. And the sad reality in dentistry is, even if something's really, really good, if we don't buy enough of it, they discontinue it. So they all went away. Well, 3M got smart and said, maybe with CAD/CAM we have an opportunity to bring something like that back. So they took zirconia particles, which you guys are learning pretty strong stuff, and they mixed that in with composite and said, what do we get? So they have a block that they released probably 7 months ago or so that is a hybrid material. And what you'll see in the next 3 or 4 months is everybody else is going to do the same thing. Because that's what they do. It's like living in the suburbs and somebody mows their lawn. Everybody has to go out there and mow their lawn at the same time. Same process. So it's a really good block in certain applications. It's not the greatest block in others for all the reasons it was good 10 years ago and all the reasons it wasn't the best 10 years ago. But there's a place for it. Yeah? Great question. So what occasions might there be that we would need a temporary? What do you think? Could be. Could be. Yep, that's one place. Yep. So that's an instance for sure.
Just in endo, you want to make sure that possibly absence is
Yep, exactly. So that image I showed earlier, of that tooth that looked like junk, that's a tooth that I didn't do endo yet, but if I think it's going to go endo, it's like buying a car and then you drive it a lot and the engine falls out. So that tooth I put a temporary on because it's probably going endo and I don't want to put a beautiful crown on and have to put a hole in it. And I sure as heck don't want to cut it off and put a new one on there because you may or may not have seen yet, if you bond things well to teeth, they don't come off. It's not like a gold crown or a PFM where you can make a little slice in it and take it off in pieces. You literally have to take, prep every bit of it off. So bridges, teeth that I feel like the lab's going to do a better job than I can do, a questionable tooth. What were you going to say, Abby? Mm-hmm. Yep, so it can be a blueprint for the future. That's a great point. If I'm working on 8 teeth, 10 teeth, 12 teeth, I want to be really comfortable that that person is going to love the way their teeth look. So I can either mock them up and show them, which sometimes is pretty straightforward and sometimes is impossible to do, or I can build temporaries and say, you know what, walk around with these for a month or 2 months or 3 months and tell me what you think. And that's a great point. So it's about how it looks, but if I'm totally changing their occlusion, it might be that I want to make sure that they're comfortable, that their jaw joint's comfortable, things like that. So the bigger the dentistry gets, the more you may want to take your time. If depends what material you're using. If you're using, what do you use at school, like Snap or something? Yeah. Oh, thank God. So Integrity and ProTemp, that whole category of materials is probably about $4 or $5 a tooth, so long as you get it on the first shot. Does that happen a lot here at the school? Okay, so call it $15 as a dental student in materials, and then whatever time it takes you. It's comparable to that. So now if I had a single tooth, I would never have CEREC make my temporary. In fact, if I had 2, 3, 4 teeth in a row, I probably am never going to do it. Because I've done enough temporaries with Integrity now that I can make 6, 8, 10 temporaries pretty quickly, and we can do it in one shot. But it's only because I've done it 1,000 times. And you guys will get there too, trust me. But if I have a mouthful of temporaries that I want to be on there long term, like Abby suggests, now I may want to use something that's stronger. So these temporaries literally are composite. And if I need someone to be in there for 3 months or maybe longer. So I'll give you one more for instance that kind of relates to this. Sometimes people come to your office and you're going to work on all their teeth. You know, they've got a mouthful of stuff that's bad for a lot of different reasons. And say, for example, you come in and I'm going to work on 28 teeth. In private practice, on average, that's going to be $50,000. So there are some people who are going to walk in your office and they're going to write you a check. Here you go. There will be some people who come in your office and they're going to hand you $50,000 in $100 bills. And then there are going to be the rest of the world, you know, the 80% who say, you know what, I get it, but I don't have $50,000 to spend on my teeth. So our perspective is this. You know, and here's what happens in dental school. And it's not a bad thing. It's sort of the product of the environment. In dental school, what has to happen, sometimes because of the patient and sometimes just because of the time it takes to do things here, at some point people make a choice and they say, we're going to have to take a tooth out, right? That happens. It's not the end of the world. Sometimes you need to do it. And in private practice, that happens probably even more than dental school because a lot of dentists are going to look at it and they're going to do just what you did in the background and be like, $50,000? Who's going to spend $50,000 on their teeth? Here's what I'll tell you. Almost everyone will spend $50,000 on their teeth if you fit it in their budget, right? If somebody told you you could own anything that you really wanted in this world and they could make it work in your month to month, would you do it? Most of us would do it. So for us, because we own this technology, what I can do is I can prep all the teeth at one time. Because what I really want to figure out is their bite, right? I don't want to sacrifice the big picture to make it affordable just for today. I want my final result to be excellent. And I feel like if you have $1 million and you have $20, that you both still deserve the best dentistry I have to offer. So what I can do is I can prep all the teeth. I can build long-term temporaries out of composite. Because what I know is if I do my job and I put that temporary on there well, I probably have 5 years if I do my job well. And I have a patient who agrees that they're going to come in, you know, every 6 months for their hygiene. I have an opportunity every 6 months to make sure something's not going horribly wrong. And if it is, I can intervene and I can correct it. So if we make that deal, then what I can do is give you, a $1 million treatment plan over 5 years, and now all of a sudden it's not so heinous. You know what I mean? It's not as bad. So that's a really great place that I love temporary materials that I can do on CEREC. But honestly, outside of that, I make Integrity temps if I'm going to do it. Someone's going to be in temporaries for a month, You know, I can make an integrity temp, and I have no concern that a month later it's going to be there. And it doesn't matter how many teeth it is. It's going to be fine. And it's just a product of doing it all the time. When you guys get really proficient at it, you're never going to make a temporary that you worry about coming off. You're going to worry about getting it off, because you're going to have great preps, you're going to make a great temporary, and retention's going to be there, and everything's going to be awesome. But in school, when you're learning, just like when I sat where you're sitting, I went home and thought, okay, when's it coming off? When am I getting the phone call? When's it going to break? You know, when's this going to happen? All that stuff goes away with practice. So these are kind of the hallmarks of when you use CAD/CAM. You really do need a great prep. You really do need great isolation, which is why I like the laser, because it makes my isolation really, really simple, and it makes it fast. And you really need great pictures, which to me, again, is why OmniCam is kind of king of this jungle right now, because I can't mess my pictures up anymore. And I'm thankful for that. So great preps, we're not going to waste time. You guys are learning in school what a great prep is. All I'll tell you is for CAD/CAM, you really do need it, because now you're the lab. So if you do an okay prep and you make an okay impression and you send it to an excellent lab, they can kind of fix things for us, right? But now you're the lab. So you really need to, you're handling everything from A to Z, and it needs you to be your best. Otherwise, you're going to have to be the person who fixes it on the other end. And I'm just here to tell you it's a whole lot easier to fix right here. This is the fastest, easiest way to make things go smoothly, and that's just make your preps look pretty good. You'll see most of this online, so I won't belabor it, because I know we're getting to the end here. But long and the short of it, a couple real key points. One of the biggest places people mess up with CAD/CAM is they under-reduce teeth. If all ceramic restorations need 1.5 millimeters or 2 millimeters, depending on what type of material it is, you have to give it that thickness, or you're going to have a whole host of problems, which you'll see when you guys watch those videos and when you actually do it. We'll mess some up on purpose so you see what happens. The other thing is, you know, keep in the upper right-hand corner, keep things really, really smooth. It's just easier for the camera to read it. And then the last thing is, the only difference between wax, you know, which is what happens in a lab if you don't use a milled restoration, or CAD/CAM, which is milling, is you can't have any really sharp angles for one reason. There's a burr that's making the tooth. And that burr, the smallest burr in the chamber, is 1 millimeter in diameter. So if you prep an angle that's smaller than 1 millimeter, then you have that situation, then your milling machine has two choices, right? If it's trying to make you this shape, but it doesn't have any ability to do it, what does it have to do? Exactly. And you can tell your machine, I want you to overcut it or I want you to undercut it, but it has to do one of the two. So that goes back to that first image of prep. If you just take this out and clean it up a little bit, all that goes away, and it gets to be real easy. Isolation, we talked about lasers. You guys know you kind of have to have retraction. Same rules apply as you're going to make a physical impression. If your patient's drowning in blood and saliva, you can't get a good picture. And whatever you would do to get a good physical impression, you want to do those things to get a good digital impression too. We kind of talked about blue versus Omni. Those are a couple of pictures. Let's go right through. All this stuff, like I said, is online, so we'll show you how to put margins on, how to modify that proposal. But the lesson is, if you give it a great prep and you take a great picture, you're going to get a really great proposal. And you're not going to have much to do, if anything, to do. If your prep isn't so good, or your picture isn't so good, or they're both not so good, there are ways to fix it. But again, if we're talking about efficiency and time management, you don't want to spend 10 minutes putzing around the computer when the computer can do it all on its own. You'll get to a point when you like it, you're going to mill it out of one of those blocks. And the long and the short of it is, if you haven't seen this technology up close, there are some of you who will hear from some people that these don't fit. I'm glad we're doing hands-on, because you will see for yourself how well they fit. And they will fit, I promise you, better than any restoration you've seen in school so far. Better, I don't care if it's gold. They will fit better than gold. It's amazing, amazing technology so long as you give it what it wants. And it's kind of makes me chuckle every day when Christy and I sit together and we try one in. You know, that just came right out of a milling machine. Nothing's been done other than taking a sprue off of it. And it's silly, but I still get giddy when I try one in, and it's perfect every time. It just makes life so much easier. Depending on what type of ceramic you use, some you have to glaze, some you don't have to glaze. We can talk about all that stuff in hands-on. Any of you who want to go back to Ivoclar, they will run a course for us on staining and glazing. You can see how easy it is to do and how easy it is to make teeth look awesome. It's pretty fast. There's a lot of stuff to make teeth look real that happens before you start, the whole paint by numbers thing. It's not hard. It's just stuff to know. They'll go through that if you want. And then I won't talk a whole lot of bonding. We'll do some bonding stuff with them, and we can do that online as well. But suffice it to say, if you're going to enter the world of all ceramics on a very routine basis, your life is either going to be really, really happy if you bond well, or really, really awful if you don't. Because the reason you still learn how to do amalgam in dental school is it's really hard to mess up an amalgam. If there's a little bit of saliva, if there's a little bit of blood, you can still put amalgam in a tooth, and it's probably going to last 15 years. It might be a mess when you take it out, but it's still going to last you 15 years. If you're bonding and you have a little bit of blood or a little bit of saliva in less than 2 years, you're in trouble. And it's kind of a bigger mess underneath there. But if you bond well, 20 years later, 25 years later, you're going to have awesome dentistry that's still there, and people who are doing a whole lot less endo, than we did before. We literally ran our numbers at the end of the year. We check everything year to year to see where we are. We do 40% of the root canals today, so as of 2012, than we did 7 years ago. I mean, that's crazy, right? It's a significant change and shift in dentistry for our patients, that they get half the root canals today than our patients got a very, very short time ago. And honestly, it's because we're a lot more conservative today. We do a lot more partial crowns than we do full crowns. And because we bond, we're saving a lot more natural tooth structure than we could at some point. But you have to know how to do it. So what's next is really up to you guys. So these are some of the things that we're doing at other schools and some of the things that we're talking about doing here. If you want them, please let us know. And if you want other things, please let us know. Because like I said, this is about you guys. I'm not here to teach you stuff that I already know how to do. I want to know what you guys want, and we'll get it to you. But getting TS is going to be all about getting you guys through clinic so you can actually get your requirements, even if you don't have maybe a high volume of patients. There's a lot we can teach you about having those patients say yes to you so their dentistry makes sense. And it's very different than what you learn in school, only because school runs out of time. They don't have time to teach you this stuff. We've got some really cool stuff for building your financial future. Is anyone here in the finance club? That's good. Okay, so we're probably going to talk to Dr. Gambacorda. I sat down about a week and a half ago with some people he and I both mutually know to bring you guys a program that they hadn't planned on bringing to UB. It's wicked. If you're interested in it, it's going to be something that they provide to all of their clients. It's going to help you look at your financial future today, through the time that you want to walk away from dentistry and plan for it and figure out whether you're making, good choices or bad choices. And you can still make the bad ones. I've made plenty of them along the way. But if you know what you're making, at least you're kind of well informed. But that's going to be really cool. If you want to learn more about oral cancer screening, there's some cool devices about that. We'll post some of those online. We'll do the same thing for shade taking. And then Kerr approached us last week. They've got a pretty cool system to do composites where instead of manually condensing, they have a composite that was engineered for a delivery system that they patented, that it delivers the composite. It's packable. You can cure it up to 4 millimeters of depth. So it's more of a bulk fill. It's designed to increase efficiency and effectiveness posteriorly. I have not used it, incorporated it in my office, but I know some pretty prominent people around the country who have. It's got pretty good reviews. So if you guys want to learn about it, they are happy to kind of open their doors and bring us a bunch of units on a Thursday evening or a Saturday or a Tuesday or whenever we want for us to play around with them. So let us know what you guys want, please. And we'll start getting the hands-on stuff ready to roll, and we're here for you if you want or need. So Thanks for hanging on a Saturday.